Corticosteroids, these are actually hormones which has glucocorticoid, mineralocorticoid activity, as well as they also have androgenic activity. Now, these hormones are secreted from adrenal cortex, and the circulating corticosteroid, they inhibit actually ACTH from the pituitary as well as CRH from hypothalamus, so that it actually gives the negative feedback regulation to this hypothalamus pituitary axis, because we have this hypothalamus pituitary axis. So secretion of steroid is governed from hypothalamus pituitary gland and to the adrenal cortex. Now there is one very interesting fact that the effect of adrenaline noradrenaline is markedly blunted if there is a deficiency of mineralocorticoid or steroid. Hence, those patients who have septic shocks or those patients who are critically ill, they need or they have deficiency of mineralocorticoid activity. That is the reason why those patients with hypotension in sepsis, septic shock, they improve markedly with hydrocortisone. Hydrocortisone is a steroid basically. They provide that mineralocorticoid, glucocorticoid activity, and that helps to cut down the blunting effect of adrenaline and noradrenaline, which is there in usually sepsis and septic shock. Now, when we talk about glucocorticoid, the name itself suggests that it has significant effect on carbohydrate, protein, and fat metabolism. When we talk about mineralocorticoid activity, they have activity on sodium, potassium, and fluid retention. Now, what these mineralocorticoid do, or what these steroids do, they actually increase the sodium absorption, reabsorption from distal convoluted tube. So it will increase the sodium in the blood. Automatically, increased sodium will cause increased water absorption. So there will be sodium and water retention. This is the reason why patients develop edema. Patients gets into a higher blood pressure. So, because of sodium retention, reabsorption, there will be increased potassium and hydrogen excretion. That is the reason why the deficiency of this steroid causes sodium loss, even if there is sodium deficiency state in the body. This kidneys absorb water without attendant sodium to maintain the extracellular fluid volume. So, net the sodium in the blood is reduced. So there is excess of water which enters the cell. There is cellular hydration and decreased blood volume, and that raises creatinine. So this actually causes the dilutional hyponatremia. Now, accompanied by hyperkalemia and acidosis, this potassium is replaced for sodium. It is always the thing that body always try to retain sodium. Then in exchange of sodium, hydrogen is given up, and again its hydrogen is very important. That is the reason why hydrogen is again taken up, H plus ion, and potassium is excreted. That is the reason why hypokalemia is very common. So in mineral corticoid deficiency, sodium is lost and this potassium is preserved, causing hyperkalemia in deficiency of steroids. And whenever we use steroid, sodium is preserved and potassium is lost. That causes hypokalemia and weakness associated. In acidosis, this H plus is also preserved and sodium is lost whenever there is acidotic state. Hence, whenever there is mineral corticoid excess, edema will occur because of sodium and water retention. This sodium and water will keep more fluid in the blood volume, in the blood vessels. So automatically it will cause high blood pressure. It will increase the blood pressure. Sodium will be retained in excess, so automatically H plus and K plus are excreted, so it will cause hypokalemia. And because of the hypokalemia, there will be alkalosis. So, when we specifically talk about glucocorticoid, they promote glycogen deposition in the liver and they promote gluconeogenesis. They inhibit the glucose utilization by peripheral tissue, so they tend to cause hyperglycemia. So this high blood sugar is extremely common problem of steroids. So steroids very commonly cause hyperglycemia, and very commonly whenever those patients who have diabetes, the sugars they increase in so much extent. Many of the patients may land up in DK also, diabetic ketoacidosis also. Many of the patients may need increased insulin dosage for particular like 2 days or 3 days until the patient is on steroid. There are so many patients of rheumatoid arthritis or COVID or ARDS or pulmonary edema, or atypical pneumonia, those patients who need steroids very badly. And in those cases, those patients who are obese, those patients who have insulin resistance, they very commonly land up in hyperglycemia. So hyperglycemia is very common problem of glucocorticoid, and that then again causes insulin resistance. These glucocorticoid very commonly protein breakdown. So steroids over long-term period will cause muscle wasting. This long-term period is at least more than 14 days. They again cause significant loss of bone, thinning of the skin. Thinning of the skin, that is the reason why the patients will develop ecchymosis. The patient's skin will be very friable, very fragile. So increased ecchymosis, skin ulcers. This is very common problem with the glucocorticoids, as there is addition of edema, so there is deposition of excess water in the skin. This thinning of the skin, fragile skin, friable skin, ecchymosis increases markedly in those patients who are admitted, especially in the hospital, and especially if the patient is elderly. This protein breakdown increases glucose in the blood, and urea also increases. So very commonly those patients who are admitted in the hospital, we can see that after starting the steroid, the blood urea value may go up. It should come down as soon as the steroids are reduced after 2 to 3 days. So overall, because of the protein breakdown, there will be catabolism, and there is also increase in uric acid excretion. So these are the effect of glucocorticoid on this glucose metabolism. Regarding fat, these steroids promote lipolysis. That is how it increases glucose. That is how it increases this gluconeogenesis. This triglyceride breakdown is also enhanced, and subcutaneous tissue over extremities loses fat, and this fat is deposited on face, neck, in the central area, on the shoulder, and causing moon-like faces, fish mouth, and buffalo hump. So, in short, this type of tissue distribution is usually seen with Spider-Man, who has very thin extremities, but the patient or the person will have central obesity, moon-like faces, fat over the sternum, abdomen. So this occurs why? Because of the peripheral adipocytes are very less sensitive to the insulin, and they are more sensitive to steroid facilitated lipolytic action. On calcium metabolism, what the steroids do, the glucocorticoids or the steroids, they inhibit intestinal obstruction, and they enhance renal excretion of calcium. That is the reason why the spongy bones they lose so much of osteoid. That is the reason why those patients who are on steroids for a very longer duration, they lose so much of bone. They are so much osteoporotic, and this is one of the reason why those patients who have rheumatoid arthritis, systemic lupus erythematosus, or inflammatory bowel disorders, they need steroids for so much of duration. Those patients who have Steven Johnson syndrome or TEN syndrome or any other immunodeficiency disease, or where the steroids are very much necessary, they lose so much of bone. They get osteoporotic, and the fractures of long bones, vertebral bones, it is so much common because of this steroid, because of this effect. On cardiovascular system, this glucocorticoid, they restrict capillary permeability. They maintain the tone of arterioles and myocardial contractility. And this effect of restricting the capillary permeability is very commonly used for capillary leak. Very commonly, those patients who have dengue, or those patients who have significant SIRS, systemic inflammatory response syndrome, or septic shock, those patients who have huge pleural effusion or ascites, in especially in dengue, There is significant increase in capillary permeability, causing water leakage into the third space, like in pleural cavity, ascitic cavity. So these patients will be dehydrated in spite of giving significant amount of fluid because of increased capillary permeability. So whatever amount of fluid we give, that all gets leaked into the pleural fluid, pleural space or ascitic space. So in the blood vessel, there will not be blood volume or blood fluid, so blood pressure remains low. In that case, in that scenario, the steroids can be used to reduce the capillary permeability so as to maintain the blood volume, to maintain the tone of arterioles, and to maintain the myocardial contractility. This adrenal sufficiency causes low cardiac output, arteriolar dilatation, and poor vasoconstrictor response to adrenaline, and there is increase in capillary permeability. And the adrenal insufficiency can be tackled directly by the steroids, because steroids, they do have this mineralocorticoid activity, and this capillary permeability can also be tackled by steroids. On muscles, hypocorticism means reduced levels of steroids. It will cause hypodynamic circulation because there will be reduced sodium retention, reduced water. So overall, there will be reduced blood volume. So there will be reduced circulation in the muscles. So it will cause weakness of the muscles. When there is excess of steroid, there will be excess of mineralocorticoid activity. There will be hypokalemia. As we know, sodium is retained, and hydrogen and potassium, they're excreted, so more of a potassium is mostly excreted. So hypokalemia and potassium is extremely important for activity of the muscle, for refractoriness of the muscle, and for the stability of the muscle power. That is the reason why this hypokalemia will lead to weakness. And this excess of glucose corticoids over a period of months, years, they will cause muscle wasting, myopathy, and they will again cause weakness. On central nervous system, these steroids, they commonly cause mild euphoria. That could be the reason why in town, whenever DEXA is given for any indication, patients usually feel very, very, very great and relieved. But very commonly, the steroids can cause insomnia, depression, and psychosis. The psychosis is very common, especially if the patient has multiple disorders, multiple diseases, sepsis, MODS, and if the patient is in the psychosis. And this high doses of steroids very commonly lower the thresholds for convulsions. So if the patient has epilepsy, road traffic accident, or if the patient is on neurotoxic drugs, the patient can get convulsions, and that can be exacerbated by the steroids. On stomach, the acid secretion, pepsin secretion is increased by steroids. So steroids can definitely increase the acidity of a patient. On lymphoid tissue, steroids or glucocorticoid, they enhance rate of destruction of lymphoid cells, especially T cells more than B cells, and this marked lytic response is shown by malignant lymphatic cells. Hence, this is very commonly a chemotherapeutic drug. Very commonly in so many lymphomas, steroid acts as a chemotherapeutic agent. Chemotherapy. Very commonly, glucocorticoid increase the number of RBCs, platelets, neutrophils. That is the reason why those patients who have dengue or those patients who have viral infections, very commonly getting admitted with leukopenia and thrombocytosis, they are given steroid shot for 2 to 3 days so that this platelet count increases and neutrophil count also increase. One more important thing is these neutrophils, they usually have the toxic granules. The neutrophils, which are one of the largest cell in the blood, which kill the bacteria, they have these toxic granules. These toxic granules directly kill so many bacteria, and this is how our body is protected. But these steroids will reduce these toxic granules significantly, so that the killing of the bacteria can be hampered, and patient can land up into sepsis or severe sepsis. And this glucocorticoid decrease lymphocytes, eosinophils, and basophils. By reducing eosinophils, very commonly allergy, hypersensitivity reactions can be controlled. That is the reason why they are one of the excellent drug for asthma, COPD, exacerbation, allergies, hypersensitivity reactions because they decrease these eosinophil reactions. As soon as the blood counts, that is the platelet count, neutrophil count, should come back to normal after 24 to 48 hours of stopping the steroids. Regarding inflammation, glucocorticoids suppress inflammation. They reduce capillary permeability, as we already spoke. This we use in dengue uh, or other viral illnesses where there is excess of ascites or pleural fluid. They reduce the local exudation. They reduce the cellular infiltration. That is how it reduces the inflammatory signs locally, like swelling of the knee, or whenever some patient get injury related swelling or post traumatic swelling. Steroid can reduce the cellular infiltration and can reduce the swelling, redness, heat on that particular area. This Also, steroids inhibit phagocytic activity of neutrophils, macrophage. That is how it can increase the infection chances. So they inhibit capillary proliferation, they inhibit collagen deposition, they inhibit fibroblast activity, they also inhibit scar formation. So very commonly, whenever a lipoma excision is done or hypertrophic scar excision is done, there locally steroids are given to prevent this scar formation. The collagen deposition is inhibited, capillary proliferation is inhibited, so healing can be impaired. That is the reason why in wounds, any patient who has road traffic accident or injuries or diabetic foot or any time, those at that particular time steroids are usually not given or they are discontinued for some period of time to promote the wound healing. The signs of inflammation like redness, heat, swelling, pain, they get markedly better with steroids. And the steroids limit recruitment of inflammatory cells at local site, and they also reduce the production of pro-inflammatory mediators like prostaglandins, leukotrienes, platelet-activated factor by indirect inhibition of phospholipase A2. On immunological and allergy conditions, steroids very commonly suppress hypersensitization and allergy. That is the reason why for allergy, for asthma exacerbation, COPD exacerbation, they are very commonly used to rapidly curtail the symptoms, to rapidly control the symptoms. For hypersensitivity reaction or for a rash, for urticaria, steroids can be excellent drug to reduce these symptoms markedly. In vivo, that doesn't impair antibody production and complement function. But the glucocorticoid cause greater suppression of cell-mediated immunity, that is T cell-mediated immunity, where the T cells are primarily involved. They also markedly reduce the IL-1 release from macrophage, and they also inhibit the IL-2, that is interleukin-2 formation, that is needed for T cell proliferation, causing suppression of natural killer cells. This can be used in severe sepsis or SARS, where actually, apart from disease, this severe inflammatory response syndrome kills the patient. Those patients who have severe sepsis or road traffic accident or any injury, in that case, the markedly high inflammatory response of our body can cause multi-organ dysfunction, can damage kidneys, heart, muscles, bone, everything. That time, using steroids partially can curtail down this IL-1, IL-2, and can cut down the systemic inflammation and can save the patients. So these were all the responses or effects of the steroid. I'll be again coming with detailed things of particular drugs. Thank you.